Neither I or my co-authors have any conflicts of interest to disclose. As many of you know, guidelines were developed for diagnosing non-progressive labor by a collaboration of the NIH, ACOG, and Society of Maternal-Fetal Medicine. These guidelines were mainly based on data from observational studies, primarily the Consortium for Safe Labor Study. The conclusions from this study that are important to the guidelines in our trial are that many women do not enter active labor until they reach 6 centimeters of dilatation. Many women progress far more slowly than 1 centimeter per hour in their active phase. And that intervention should only occur when there is an arrest of progress, and that slow but progressive labor should be considered normal. Practitioners are also encouraged to permit a longer second stage of labor. Therefore, our trial focused on 3 guidelines that encapsulated the new paradigm. The first was that a failed induction of labor should be only diagnosed when there's been a failure to generate regular contractions and cervical change after at least 24 hours of oxytocin administration with artificial rupture of membranes. The second guideline concerned diagnosing first stage labor arrest. It stated that a prolonged latent phase should not be an indication for cesarean delivery, that slow but progressive labor in the first stage of labor should not be an indication for cesarean delivery, and that ideally first stage labor arrest should only be diagnosed at or greater than 6 centimeters of dilatation with membrane rupture, and when no cervical change had occurred for 4 hours or more with adequate contractions, or 6 hours or more if contractions are judged to be inadequate. We conducted a clustered randomized controlled trial of a knowledge translation program of these guidelines in 26 Canadian hospitals. The primary outcome of the trial was the rate of cesarean delivery in primiparous women with vertex presentation in labor at term. Secondary outcomes include spontaneous vaginal birth and maternal and neonatal safety metrics. The main source of our data was the Alberta Perinatal Health Program database, which records all data on Alberta births since 1990. Our analysis was based on 45,193 deliveries at the intervention sites and 43,725 deliveries at the control sites. The consort diagram of the trial is documented here. The characteristics of the subjects at the control and intervention sites were clearly quite similar in the baseline period. This slide shows the cesarean delivery rates at our control and intervention sites and demonstrates that we observed a small but not statistically significant reduction in cesarean section at the intervention sites. We did, however, observe a statistically significant increase in spontaneous vaginal delivery at the intervention sites. Nor a change in neonatal sepsis diagnosis, the occurrence of cord pH less than 7, the rate of APGAR scores less than 10 at 5 minutes, or neonatal resuscitation requiring C. Additionally, we observed no change in the rate of neonatal resuscitation requiring intubation and positive pressure ventilation. There was also no change in the rate of neonatal asphyxia or the rate of moderate to severe hypoxic ischemic encephalopathy or therapeutic cooling. Infant birth trauma was also not changed, nor was the rate of intrapartum stillbirth or neonatal death. Concerning other maternal outcomes, there was no change in the rate of postpartum hemorrhage, or maternal blood transfusion within 30 days of delivery. Additionally, we observed no change in the very rare occurrence of hysterectomy within 30 days of delivery. Compliance measures. Our data also suggests a small decrease in the rate of cesarean delivery in the latent phase, or less than 6 centimeters in both spontaneous induced labor. However, the change was not statistically or clinically significant. Our study nurses performed a chart audit of all cesarean deliveries due to dystocia at intervention sites from 2017 to February 2020. Overall, 31% of deliveries were consistent with the guidelines, with compliance at the individual sites ranging from a low of 13% to a high of 50%. In conclusion, we did not observe an effect of the intervention on our primary outcome, which was cesarean section in first-time mothers. We did, however, observe a significant increase in spontaneous vaginal delivery rates. We feel that our trial demonstrates that it is safe to apply these guidelines, as we do not observe any increase in neonatal or maternal morbidity and mortality. We also expect that if adherence to the guidelines were greater, there may have been a more significant reduction in the cesarean section rate.